Good morning. This is Dr. Jim Waller from Tri-State Colorectal Surgeons. I'm going to take the opportunity this morning to educate the public and our patients on another important anorectal problem, that being something that is called an anal fissure. Anal fissures are one of the most common problems that we see in our office, and in fact, certainly rival hemorrhoids in terms of how the number of patients or how often patients present to our office with a particular problem. The symptoms of an anal fissure. Anal pain, rectal pain is it's commonly caused, occasionally bleeding, and in fact, I would say that the most common cause of pain and bleeding that we see with bowel movements is secondary to an anal fissure. Now, what exactly is an anal fissure? Well, an anal fissure is a small crack or tear in the lining of the external anal canal, and to um, help you visualize that, I'll pull up one of my illustrations from the American Society of Colorectal Surgery manual on colon and rectal surgery. And this is an illustration of the lower rectum and the anal canal. And if you've watched one of my previous broadcasts, you will know that I've gone through a rather extensive explanation of the anatomy of the rectum and anal canal. But let's suffice it to say for today that what we're going to talk about is basically the external anal canal, and that is the part of the anal canal lining the lower part of the anal outlet, and it is very sensitive to pain. And as I've said before, many people who have ever had an anorectal problem where they had pain, they know what I'm talking about. So an anal fissure occurs in this part of the anal canal, and specifically, really in the lowermost part of the anal canal here. And a fissure consists of a crack or tear. Generally, it has occurred because of a patient having a hard bowel movement. It can also occur in patients who are having significant diarrhea for one reason or the other. Anything that might cause some irritation, some breakdown of the modified skin in the anal canal can certainly result in a fissure. We see this quite often when patients have become constipated for some reason. Yeah, can't tell you how many times I saw patients come to the office who had been on a trip, had been traveling, developed constipation, which is very common during travel. In fact, developing constipation or other changes in bowel pattern is very common during different things that can occur in our life, whether it be stress, travel, medications. A lot of different things can cause changes in your bowel pattern, but we tend to see anal fissures occur in patients who have been constipated and they've had to strain, and that's kind of a common sense reality. If you're having to strain to go to the bathroom, you have hard, dry stool, it's more likely to cause a crack or tear in the lining of the anal canal. So that's the most common cause of an anal fissure. And as I said, probably the most common cause of pain in those patients who present to our office complaining of pain. As I've said in previous discussions, most healthcare providers and most patients, when they have any pain at all, in fact, when they have any symptom, they will typically come in and say, "Hey, doc, I've got a hemorrhoid." In actuality, we see many more fissures than we see problems with pain being the result of an issue with a hemorrhoid. So when a patient presents with a fissure, the first thing we're going to do is take a history. Um, we can usually make a very accurate, educated guess of what's going on in a patient simply from taking a good history. But once we take a history, we will take a patient back and do an examination, and that examination will consist of evaluating the external anal canal. One of the things when I teach courses to the medical students on evaluating patients for anorectal problems, one of the things that I always tell them is do not attempt to do extensive examinations on patients who are having pain. They quite often are going to leave your office very upset. And if a clinician understands the anatomy and physiology of the anal canal, they understand that anything down there that's causing pain is going to be difficult to examine without some level of anesthesia. And, I was taught in medical school that the only reason for not doing a digital rectal exam or looking into the rectum with a scope was no rectum or no finger. I subsequently learned through experience and through my mentors and my colorectal surgery training program that that's not true. Now, of course, the reason that we were told that by our surgical instructors during our surgical rotation at medical school was that they were deathly afraid that if we didn't do an exam, we weren't going to pick up a cancer within the rectum. I would say this, however, and this is what I teach the students and the residents when I speak with them. We're going to check the rectum. We're going to do a thorough examination on these patients, but it does not have to be done in the office when the patient is in pain. So that being said, what we're going to do, history, as I mentioned, we're going to take a look at the external anal canal, and I want to show you the way that we see that. And I've used this example on other broadcasts. When we look at someone's bottom, and I like to use my hand because I did this for 30 some odd years when talking with patients. I say, this is your anal opening. It's closed. The muscles keep it closed. And so when we look at the anal canal, we're looking at a closed opening because of the sphincter muscles holding it closed. Interesting thing about anal fissures. The anal canal is very sensitive to pain anyway. But when you have an anal fissure, we tend to see some element of sphincter spasm. In other words, the muscle goes into spasm, the internal sphincter. And any of you have had back issues or even other orthopedic issues, understand that muscle spasm is a very common component with those type of injuries, probably as a result of the body trying to splint itself to allow it to heal. In the case of an anal fissure in the anal canal, the muscle spasm sometimes causes a lot of the pain. Therefore, don't be poking instruments or your finger into a person's rectum. The problem is not in the rectum. The problem is in the anal canal. So we start our exam by just looking from the outside. And I'm not sure how well it will show up given my lighting, but I'm going to hold my hand up now a bit. And I have made a little ink mark in my hand back toward the back because, as I may have shown you in previous discussions, when we examine patients, we have them on their left side. So they're lying left side down. So this would be the right side. This would be the front. This would be the back with the tailbone sitting back here. 90% of fissures occur in the back part of the anal canal. We're not exactly sure why that is. It's suspected that it's either secondary to muscle tone or perhaps blood supply within the anal canal. But 90% of fissures occur in the very back part of the anal canal. Only about 5-10% in the front, and even fewer over on what we call the lateral edges of the anal canal. So what we do first is we look from the outside. Quite often, because there's a bit of spasm and because the anal canal is closed, you won't readily see the fissure at first. We will then just simply spread the skin a little bit. And when we do that, we can quite often then see the little crack or tear because it lies right at the opening. It really, in very few cases, does it extend any distance at all into the anal canal itself. It's right at the verge of the anal canal and what we call the anal verge. And so it's very, very readily apparent by most clinicians by simply looking at the anal canal from the outside, spreading the skin a little bit, and finding the fissure lying right on the anal verge. Sometimes that's not the case. Sometimes, in order to figure out what's going on, we might have to take the patient to the operating room and give them certainly some sedation and local anesthetic in order to do an adequate exam. But by far and away, most of the time, we can make the diagnosis by having taken a history, getting this history of, in most cases, constipation, but sometimes after a flu bug with some diarrhea and irritation down there, you may get some cracking of the skin, or what we call the anoderm as well. But generally, by taking a history and doing an examination, we can see whether the patient has a fissure. There is sometimes some swelling associated with the fissure, which gets mistakenly called a hemorrhoid. In fact, there's an old medical term for that, called a sentinel pile. And what happens in the anal area with almost any condition which causes any type of inflammation or injury is you can get swelling because the skin down here is very loose. It has to be. That skin has to be able to open rather widely to allow passage of the bowel movement, and then also be able to be contracted and closed during most of the time. So it's very common because of this rather loose skin down here that with anything causing any inflammation or any kind of an injury, that one can develop some swelling of the skin. And that term sentinel pile refers to the fact that eons ago, when doctors were first figuring this out and doing exams down there, they would see some swelling at the exterior end of that little crack or tear. You'd see some swelling of the skin, much like you get swelling with any injury in the body. That gets misdiagnosed as a hemorrhoid very, very often. As I've said in previous discussions, almost anything in the anal care area will get called a hemorrhoid by clinicians who are not that familiar with the anatomy and physiology and diseases of the anal area. So seeing a sentinel pile is what those are called, or sentinel skin tag. You may remember pile is an old word that doctors use for hemorrhoid. So seeing a sentinel pile, or what we call now a sentinel skin tag, quite often is also one of the hallmarks of the exam when you see a patient with a fissure. So the question then becomes, what do we do with a fissure? Well, knowing that the cause, what we call the etiology, in most cases has been a disturbance in the bowel pattern, and usually that being constipation, we treat the constipation. And the outcome-based evidence shows that the best way to treat constipation, if you're following a logical route of treatment, is put the patient on bulking agents. And the favorite of colorectal surgeons, and I would say probably of most gastroenterologists who also deal with GI diseases, is to put people on psyllium. And I own no stock in Procter and Gamble or Metamucil, but most people are familiar with Metamucil simply because of the advertising you see on TV. But almost every discount grocery or drugstore has their own generic brand of psyllium, and it's spelled Psyllium. So we put people on a healthy dose of psyllium. A teaspoon of psyllium has about 3.5 grams of fiber. Um, Myself, my partners typically have people take a rather generous dose. You can take a tablespoon at a time. You can take it a couple, 3 times a day. You almost can't overdo it. The psyllium that's non-flavored is a little distasteful. It tastes like drinking sawdust. So you want to mix it with something that's got some flavor, or there are flavored varieties out there. What I have tended to tell people to do is mix a big heaping teaspoon or a couple of teaspoons in just a few ounces of water or juice. Stir the heck out of it and chug it like I call it my Metamucil shot, because then you can follow that with water or coffee or tea, to get it to mix in your stomach. Because the way psyllium works, the way a bulking agent works, holds water in the stool. So you've added bulk to the stool, and you've also added water, which makes it much easier for the colon to push the stool through, and gives you, I'm not going to say it's not a laxative. The idea is not to give you loose stool, but it gives you a bulky, soft, normal bowel movement. So that's the first thing we do. We get people on some fiber, even if they don't normally need it. While we're trying to get the fissure healed, we get them on a bulking agent. In addition, we have some specific ointments that we can use down there. And generally speaking, the over-the-counter creams and ointments do not work very well. They may provide a little bit of lubrication. Some of them have a little bit of an analgesic in them to kind of help with discomfort. But because a lot of the discomfort we see is secondary to muscle spasm, topical ointments down there that are just designed to coat the anal canal a lot of times don't do much good. The thing that I would say probably most colorectal surgeons around the country use is a product called nifedipine ointment. Nifedipine is a calcium channel blocker. Some of you may be familiar with that because it can be used orally to reduce blood pressure. What it does is it gets absorbed through the skin, like nitroglycerin gets absorbed through the skin. Um, and it causes relaxation of the internal sphincter muscle, because, as I said before, we know that a lot of the pain is being caused, and those people who are having significant pain, it's being caused by the sphincter spasm. And in fact, that's a real key to getting this to heal in those people who are having significant pain, is breaking that sphincter spasm, which will give them some pain relief. And that, together with normalizing their bowel movement, will result in about 80 to 85% of fissures healing with simply that medical management alone. There are other agents that can be used. There's nitroglycerin ointments that can be used. I think myself and my partners found through the years that it was much more expensive than nifedipine. That has improved in recent years, but it was much more expensive. A lot of patients tend to get a headache with that, as patients do if they're using it for their heart. And we found it not to be as effective simply for that reason. So we tend to, in our office, use nifedipine ointment. I know where I trained, that's what we were using. And that tends to be the mainstay of treatment, is bulking the stool and the use of nifedipine ointment at least a couple of times a day. As I mentioned, we can get 80 to 85% of these to heal if the patients will be diligent and continue that routine. Something else that always works when you're dealing with anorectal diseases, because as I said early on in this discussion, a lot of the pain with almost anything that occurs down there is related secondarily to muscle spasm. That includes patients recovering from surgery. So sitting in hot water, okay, just like applying heat to any other muscle, tends to cause some relaxation, makes it feel better. And so we will also have people add what we call sitz baths. A sitz bath is a little plastic container you can put on your toilet seat, put hot water in it, and sit in that. You can also sit in the tub. You can sit in the shower, although that's a little less convenient than just sitting in the hot water. And that's particularly important right after a person has a bowel movement, because early on in their treatment, they may start feeling well within a few days or a week or so, but each time they have a bowel movement, it reinitiates the pain in the fissure itself and the sphincter spasm, resulting in more pain. So we use heat to the topical heat to the area with almost any condition in the anorectal area, but that's particularly important with fissures. If we, as I mentioned, 80-85% of people will heal when we do that. They don't get better immediately. One of the things I've always done is I tell people, hey, you're not going to be better tomorrow. Now, do we have a rare patient where they get significant improvement simply upon putting those measures in place? Yes. But most people are not going to get better right away. It's going to take place over a matter of a few days. So if medical treatment does not work, and we generally will give it a number of weeks before we give up on it, as long as the patient's improving day by day, certainly week by week, we will continue that for an extended period of time so that we can help avoid surgery. But if that does not work, those people then become candidates for other treatment. The other situation where we might recommend surgical treatment right away is where if we get a patient who comes in, and let's say their primary care physician had already been treating them appropriately, and that's the case many times. Or in those people, if they're in tremendous pain where they're almost non-functional because of the degree of pain, and it can be that uncomfortable, or whether they've been on treatment or not, and when they present to the office and they are in extreme pain, those are people we will then talk with about doing other therapies. The most common treatment that is done nowadays in the United States, and I would say around the world, is something called a lateral sphincterotomy. Now, what a lateral sphincterotomy consists of, and I'll use my illustration again, a lateral sphincterotomy consists of us using anesthesia or sedation and local anesthesia to make the area anesthetize it. We use lidocaine, Marcaine underneath the tissue. We will make a very tiny incision right in the opening. Actually, these representations, a lot of these illustrations are not exactly how the human body looks in real life. We will make a little incision right here at what we call the anal verge, and we'll use a pair of scissors and a pickup, and we will find the lower edge of that internal sphincter muscle. This is the internal sphincter muscle. This is the external. What we do is we put a nick in the lowermost edge of that muscle. We don't cut the whole muscle. The entire muscle, as you can see, it represents, this represents the internal sphincter and this the external. So here's your internal sphincter. We do not cut the entire internal sphincter. If we did that, a person might have issues with control. We put a little nick in the lowermost edge of that internal sphincter muscle. When we do that, okay, 95% of people are going to heal. And the amazing thing about this particular surgery, even though we're putting a small incision in a sensitive part of the body, because we break that muscle spasm, most people feel better right away. This is not something where it's going to take 2 or 3 weeks or 4 weeks, like it might with another anorectal surgery, such as a hemorrhoidectomy. So most people get almost immediate relief, 95% healing rate. So that's the most common thing that is performed, I would say, around the country. That's the most common thing that I did in these patients. Now, in recent years, we've gone to using botulinum toxin, which can be injected throughout the internal sphincter. And what that does, botulinum toxin is a paralytic agent, and it will give you some relaxation of that muscle for up to 3 months. And I would have to say, in my practice, I never did that because of the expense. It was tremendously expensive, quite often not covered, and the average patient's not going to be able to pay it out of their pocket. And then the other issue is the facility might get stuck covering some of that cost. And so that we were not doing that much when I was in practice. I can tell you that some of my partners have done it, and I can also tell you I recently reviewed the data and what we call our clinical treatment papers that come out of the American Society of Colorectal Surgery, and it doesn't seem to be as effective as doing sphincterotomy, but it is an alternative. And in fact, in people who may already have a little bit of muscle weakness for one reason or the other, and that particularly applies to women, especially if they've had kids, it might be your first line of treatment because you don't want to do any further, potentially cause any further injury to the muscle complex that might impair their control. So that's something that we're seeing done, but does not seem to be as effective overall as doing a sphincterotomy. So one of the things I would say about people with fissures will ask me, what are the chances I'm going to get one of these again? They've got the same chances they had before. It's a common finding in people who come in with pain and bleeding. What I noticed in my practice, as with many medical conditions, people who develop one fissure tend to be more prone than the general public to develop another. But most people are not going to show up with another fissure, particularly if they're very careful about keeping their bowel movements as normal as possible, being aware of the fact that when they travel, or if they're in the hospital or they're taking medications, it may cause constipation. Most people can kind of be on the alert for that and make sure that even though they may not normally have any issues with constipation, they might want to increase the fiber in their diet in order to prevent constipation. Just to say a little bit about bulking agents and stool softeners, the best approach to constipation, the one that is held up to outcome-based studies, is the introduction of a bulking agent such as psyllium. Now, there are other bulking agents other than psyllium, but that is the one that's been found to be the most effective. We will generally start with that. If that's not effective, we go to what we call an osmotic agent. Many of you may be aware of Miralax, Glycolax. It's a substance that's called polyethylene glycol. It's used in almost all of our colonic preps to get people ready for colonoscopies. It's been over the counter now for quite some time, and taking a dose or two of that a day, if needed, may also help to prevent constipation. Or if we've added a fiber bulk in a person's diet and that alone is not working, that would be the next thing that we would try. So fissure, again, is a little crack or tear that occurs in the lining of the anal canal. Most commonly occurs when a person has been constipated, had to strain. It represents a little tear that is an injury to that very sensitive epithelium that lines the anal canal. Very painful, and very, very treatable. Our treatment consisting of bulking agents, sitz baths, nifedipine ointment, which will heal 85% of these. And if that is not effective, then going to surgical procedures or you might call it medical surgical procedures in the form of the botulinum toxin, as I discussed. So, hope that that has been helpful to people and that you now understand the difference between hemorrhoid issues and fissures, which, as I mentioned, much more common in our office as a cause for bleeding and pain than the hemorrhoid tissue. If you have any questions or concerns, feel free to contact me. As I always say, I will get back to you as soon as I can. Feel free to reach out to us at our website, colondocs.net, or give us a call at Tri-State Colorectal Surgeons in Evansville, Indiana. Thank you.